Hi guys, it's been so long. I feel it's been so long. I've been away for 6 weeks, 5 weeks now over in the UK. Went over to be with my mum, who wasn't too well twice this year, and while I was there, ended up in hospital. But we spent Christmas Day together in hospital and with presents and stuff. So that was really nice. And she's now back home and doing well, so that's all good. And I managed to get my book into 2 bookstores in London, which was just awesome. One thing I really wanted to do while I was there was get in touch with this Gastro chap at the King's College Hospital in London, which is one of the largest teaching hospitals, I think, in England, and has a big gastroenterology unit. Anyway, I emailed him and I rang, left messages, and nobody got back to me, which I guess I wasn't totally surprised, but I still don't get it. I mean, if you're teaching something you think you know, and somebody else says, well, look, what you're teaching, that's great. However, this is what's happened for me, and I don't have Crohn's anymore, so therefore it's not an incurable disease. Maybe changing your understanding of what Crohn's really is would be a good thing. But he didn't contact me. So I just wanted to give you a little info onto this publication that came out. A clinical review. This is what people in the medical industry do, because they do these reviews, they do these publications to get published, and that way you're going to believe more of what they're doing as being correct. Just my understanding. I'm not a doctor, remember, none of those things. Anyway, this chap, clinical review, Crohn's disease, contributed by Dr. Guy Chung Fei, consultant gastroenterologist, and Jaroslava Tumova, IBD nurse specialist, King's College Hospital, London. And this is the photograph that they put on the website. I don't know if you can see it. And all those lovely ulcers there on the lining of the bowel. So that in itself is titled Severe CD, Cobblestone Appearance Seen on Endoscopy. So here's some information. Switch off now if you're not into it. Might be boring, but I'll try and make it interesting. Okay, so section 1. Epidemiology and etiology. Crohn's disease, CD, is, now see, they're already saying what it is. Well, there's no known cause and then there's no known cure, so how do they know what it is? They can't. It's just a name. Symptoms, name. What came before the symptoms? Okay. Crohn's disease, CD, is an inflammatory bowel disease, IBD. It is a complex, chronic, relapsing inflammatory disorder of the GI tract and is characterized by patchy transmural inflammation. Transmural. Well, the meaning of transmural, because I looked it up, is the passing or administered through the anatomical wall. So the inflammation of the cells can permeate through the bowel wall and creating like pockets. Diverticulitis is one of these things. So that's what it means, transmural, going through. I just find it quite funny, as they say, this is what it is. No, this is not what Crohn's is. This is what the symptoms are that you've called Crohn's. So that can affect any part of the GI tract from mouth to anus, although the terminal ileum and right colon are most commonly affected. I want to know why. This is some of the research that I really want to communicate with Dr. Rajiri, the IBD specialist in the University of Tasmania, because I want to understand why someone gets the ulcers in the upper part of the esophagus or in the small intestine or someplace in the bowel or the ileum. Why? Not, well, there it is and that's it. Nah, sorry. It can be defined by the Montreal classification, another name, which includes the disease location, terminal colonic upper GI, and the disease behavior, inflammatory, fistulizing, or stricturing. So that's either a fistula or fissure or stricturing, closing up, scarring, stuff like that. Again, a classification. Who's Montreal classification? I should have looked that up before I spoke to you. Okay, epidemiology. This won't take long, I promise. The incidence of CD in the UK is 6.7 cases per 100,000, and the prevalence is 140 cases per 100,000 annually, although the incidence has been increasing. Why? Keep asking questions. I reckon, should I say? Well, the pressures in the world are getting more, and people are worrying and becoming more anxiety, having more anxiety. A lot of people are becoming angry at the fact that 3% of this world population is controlling the other 97%, and not fairly. I don't know. But getting back to fight or flight, I reckon there are more unhappy people, and an irritable brain will make an irritable bowel. Someone said that. Oh yeah, me. Okay. CD is a disease of mainly, is a disease, again, telling us what it is, of mainly young people, and has bimodal distribution, which is 2 peaks. With a peak incidence between 15 to 30 years old and a second smaller peak between 60 to 80 years old, although it may affect people of any age. Well, 15 to 30, one can kind of understand that. You've gone through puberty, and that's stressful enough. You've gone through your body growing. You've gone through whatever you had to go through in your family life. And then you've got to sort of become a sort of adult and try and fight your way through proving yourself to do this, proving yourself to do that. And I guess that sort of happens. And then once you've got over 30, you probably don't care so much. And then when you get to 60 to 80, well, maybe you start to get concerned because people keep saying, what about retirement and how are you going to make your money to survive and all this sort of stuff. And then people worry about, their income for the rest of their lives and what's going to support them, Again, stress. Okay, etiology. Well, that just means medicine, the cause or set of causes or manner of causation of a disease or condition. The importance of sunlight in the etiology of melanoma, i.e. what causes the problem. Hey, funny about that. Yeah, the causes of CD are uncertain, unknown to them, but it is likely to have a multifactorial etiology. So it's likely to have a number of reasons as to why. Consisting of the interaction between predisposing genetic, my thoughts on genetics. Genes don't do anything, they don't switch themselves on and off, they are switched on by signaling protein effectors and receptors, etc., etc., etc. It's not like a genetic passing, in my understanding, of course, who am I? It's more like a passing of learning how to behave, learning how to think from the people before you. So if somebody was sick before, and it could have been a stressful reaction, i.e. the thought tells the brain, this is a problem, brain sends off a negative or a chemical to deal with it, if held in the body for long periods of time. Again, I've said it before, cortisol causes inflammation to the cell. So, consisting of interaction between predisposing genetics and environmental factors, which initiate an inflammatory response, resulting in a chronic activation of the immune system, with T cells playing a prominent role. And I think I've mentioned this before. I was told once about the white cells running around the body when, what have we got to do? And they've got no bad tissue to sort of eat up and destroy, so they start working on healthy tissue. I need to get some facts about that one. T cells or T lymphocytes are a type of lymphocyte, white blood cell. Oh, there you go. That play a central role in the cell-mediated immunity. They can be distinguished from other lymphocytes such as B cells and natural killer cells. T cells, because of the nature of the thymus. Okay, blah. I'm talking to myself. Sorry about that. Genetic factors. Around 5 to 10% of IBD patients have a positive family history. First-degree relatives of IBD patients are 10 to 14 times more likely to develop IBD than the general population. Duh! It's not a genetic thing. If you have a family, a couple that are having problems and stress and their reaction to this world is anger, irritation, frustration, low self-esteem, anxiety, worry, fear, loathing, hatred, whatever, then that couple having a child especially going through the pregnancy is receiving all those stress hormones. Child comes out, family's still the same. Child is just going to react to all of this stuff with what? Stress hormones. What do? Cause inflammation. Okay. And oh God, this was good when he put, in identical twins, the concordance, you see, they like to throw these special names in, and that way the publication sounds more right and proper and stuff. Concordance means, in genetics terms, the presence of the same trait in both members of a pair of twins or set of individuals. In identical twins, the concordance rate for CD is approximately 50%. Duh! It is estimated that CD has a greater coefficient of heritability than asthma, hypertension, and schizophrenia, and is at least as high as type 1 diabetes. Don't get me started on diabetes. No, I won't. I promise. I'll hold back. I might come back on you. However, CD is a complex polygenic disease. No, it's not. Although several genes have been identified, including the NO2/CARD15 gene, each individual gene only offers a small increased susceptibility to CD. If you're looking for something, you're going to find it. And if they're finding various patterns and that becomes their Newtonian physics way of saying, yes, that's it, then that's what they'll put down. I'm probably not explaining myself very well here. But anyway, maybe I'm not understanding it well. Environmental factors, big time environmental factors. Brain most of all, because thinking creates the brain to give off chemicals. So big environment. Other environments, what you eat, drink, inhale, inject, and then stress is another. Stress to the body. I don't mean stress as in stress as in broken your neck or your arm or hurt yourself. There's going to be a definite difference in the way that the cells are affected. So environmental factors. Cigarette smoking increases susceptibility of developing CD by 3 to 4-fold and is also associated with more aggressive disease course and a lack of response to therapy. I used to smoke, gave up smoking when I was told that it actually creates a mucus that coats the villi. So you've got these little fingers, if you like, in the wall of the intestines. And that is actually part of the measuring of your intestine, the whole length of this thing. And when you smoke, you're irritating your body, which produces a mucus, and the mucus coats all over the villi. And what's the point? What's the point of eating food or good food or anything? Because it's not going to get through the bowel wall, which is what the bowel is for. The bowel, from mouth to rectum, is a hole that isn't your body. The actual medical profession see the gastrointestinal tract as being outside of your body. We're like a polo mint or a lifesaver if you're in Australia. So we're like this polo mint. We're the bit in the ring, and the hole is nothing. It's like outside of the body. So as we eat and drink, our body is designed to take nutrients from whatever we put in there, not dead food, fast food, fried food, sugar, dairy stuff, but good stuff. And in order to get the good stuff, The villi need to be clean and healthy and clear of mucus and sludge and dead meat. Just my thoughts. So, yes, that's why I gave up smoking. I'm a bit passionate today. Sorry about this. Anyway, the role of diet in the etiopathogenesis of CD has been studied, but no dietary agents have been identified, although some studies have showed a link with refined sugars. Sugar is like pouring battery acid into your body. Cancer loves sugar, and it'll help it grow like a mushroom, like a fungus. Loves it. Sugar is probably one of the worst things we could put in my body. Do I? Yes, sometimes, because I like chocolate and fruit. But I don't overdose on fruit. I try and keep it low. Seriously, fructose could still be a problem. So dietary agents have been identified. Many dietary agents have been identified with anybody who eats healthily, who eats organic food, who eats vegetarian food, who have had problems such as diabetes or arthritis or MS or other problems, and have changed their diet, dramatically to include lots of leafy greens and fresh vegetables and etc. Have found an amazing change. And on this point of MS, love to say Dr. Terry Wahls, WAHLS. Check her out. She's done a TEDx talk about feeding your mitochondria. Really important, not just for MS, but for any normal, healthy human being. And the diet talks about all the food she talks about. It's just brilliant. So yeah. So if you smoke and you've got any gastric problems, it is making it harder for you to heal yourself. If you smoke, just don't. Yeah, that was easy. Okay, other factors such as the use of NSAIDs and GI infections, have been shown to cause disease flares, but no infectious agent has been shown to be the causative link. There is no evidence that the MMR vaccine increases the risk of CD. Yeah, okay. Section 2, making the diagnosis, clinical features. Not far. Common symptoms include intermittent diarrhea with or without rectal bleeding, abdominal pain, fatigue and weight loss. Pain is a common symptom and may be caused by inflammation or, less commonly, a stricture. I want to get more information about strictures. Why would a stricture occur? Why would the gastrointestinal tract, being a muscle, actually go into a stricture? But want to find out about that. However, about 20% of CD patients in clinical remission, so you don't lose CD as far as they're concerned, you go into remission, yeah, right, will continue to have pain, underlining the importance of psychological and emotional factors in the pathogenesis. What's pathogenesis? I looked it up. The pathogenesis of a disease is the mechanism that causes the disease. The term can also describe the origin and development of the disease and whether it is acute, chronic or recurrent. The word comes from the Greek pathos, disease, and genesis, creation. Yeah. It reminds me of that film, where the father keeps going, this word in Greek, the word you can find in Greek. That was quite good. That was quite funny, but I can't remember the name of the film. Anyway, the pathogenesis of chronic disease. Extra-intestinal symptoms such as arthropy, uveitis. Oh no, I'm not going to go through all of those. Anyway, it starts to try and get technical on you and give you all these various these names. And it comes up to proteins. I just don't like the way that they're just... This is a public thing for people to read, and there's just too much in there that's I don't believe is right. And when you tell someone they're going into remission, I've said this before, you take away their hope. You say to them, look, mate, I'm really sorry, but you've got this disease and that's it. You've got it for life. So that's just the way it is. And you just go... And the other thing they told me at 14, you're going to get bowel cancer, and you're also going to have a bag. And it was like, what? And you're going to get feeling worse about that. And then, of course, your Crohn's flares up. Your symptoms get worse. And then they go, well, see, you got Crohn's. Huh? Have some drugs. They'll do you fine. They'll also line my pockets well. Anyway, moving on. Diagnosis. CD shares features with many other conditions such as infectious colitis, IBS, celiac disease and diverticulitis, and the diagnosis can often be difficult. It is just location. That's it. Infectious colitis. That's just such a wrong word to use. You don't catch it. It doesn't catch to each other. It's what's going on as a result of. Okay, range of investigations is required to confirm the diagnosis. See the table below, and best performed under the supervision of a gastroenterologist. Yep. And then it goes on, gastroenterological clinic. Basically, it's saying that, you know, your only option is to be with a gastroenterologist. I'm going to say, hand on heart, I'm not a medical person. I'm going to say that that's just not true. It's just not true in my understanding. You have your gastro near you, absolutely, especially if you're suffering from bleeding and or acute pain. And if you have a temperature as well, because that's, as soon as you have a temperature, that's your body, you know, fighting something at the time. But I actually spoke to someone this morning that I've been discussing with. Her name's Anne, because so I was trying to be really discreet when we were having the conversation. I said, do you want to shall I record this so that people can hear your story? And she said, sure. And I introduced her as, this lady in Liverpool. And she said her name was Anne and she was from the Wirral. So, lovely girl. And she's been through hell and back and been bedridden and, for 3 months when I first sort of met her, in inverted commas, about 3 years ago. And within a week or two, she was up, going down to the letterbox and then back to work and whatever. Anyway, I hadn't heard from her for a while. And she's back on the radar. And she's just doing extremely well, which is really good. She does have a stricture. So the gastro has told her, present gastro has told her that she's to have a stoma, which she has refused at this stage. And I've suggested that, because he said that there's a restriction, I suggested that she has another colonoscopy because she hasn't had one for 3 years since before the last operation, just to get more information. Because when you've got information, you've got power. Don't just blindly trust, because a surgeon can only look at you with eyes and understanding of how to cut you open and cut something out or put something in, or do both. And like a gastroenterologist can only sort of sort out your problems with what he knows and understands. So there are other options. Not me, but just hello. So look into them. I don't know whether I'll put the recording on the end of this, because this has gone on for 26 minutes. Apologies. I don't know whether it helped you at all. I certainly got passionate. But yeah, if you want to get this link to this published piece, please contact me and I will post it, or maybe I can post it somewhere. I don't know if I can. I can't post HTTP things on the internet, on the YouTube channel, but never mind. Anyway, all the best. I'll see how this comes out, and yes, yay. Talk to you soon, I hope, and I'll promise to be more regular. Well, I am really, but more regular here. Okay, bye. Okay, deciding to add this little bit of video at the end of this. It's a conversation I had with a lady by the name of Anne, who's had Crohn's disease for a while. And yeah, we connected about 3 years ago when she was fairly bedridden. She then we then connected again about 6 months ago, I think now, and she was poorly again. And so we've been talking, and she's just making great strides and sounding so fantastic. And when I heard, she sent me a message saying she was going into hospital having possibly the whole bowel removed. I sent her my book as a Christmas present because I'd just been communicating with her for a while, and she's now got her power back and doing really well and eating differently. She's blending her foods at the moment because she has a stricture. Anyway, here's the sort of interview that we had first thing this morning. So you're going to get morning face. It's just the way it is. Anyway, enjoy if you listen to it. Cheers. Bye. Okay, I'm speaking to a wonderful lady in the UK, and her situation is she's had a couple of operations, one 11 years ago, a removal from a little bit before the appendix including the ileum, and she had another bowel resection about 3 years ago. Is currently going through a few things, but anyway. Hello, I'm not going to use your name.
It's fine, it's fine, because your name's Anne.
Oh, there you go. Her name's Anne. I was trying to be discreet. When did we first connect? How many years ago was it? And you were in bed, I think, for about 3 months.
That's right. I was extremely low, extremely poorly, and it was about 3 years ago, Kit, and I'd just had a resection. It hadn't worked. And then I met you over the internet, and just talking to you over a few weeks, I was out of bed. I felt much better. Just the positivity of your advice.
Of the way you think, not. Oh, that's good.
And knowing that there's someone else out there who's had Crohn's and is now doing brilliantly, gave me hope to, shake myself, get myself out of bed, and I did. Thanks to you.
Oh, well, I mean, no, it's thanks to you. I mean, obviously you did the work, because I remember you said something like, I think within a first week or two you were walking down to the letterbox, and then
I posted you a letter.
And then you even went back to work a few weeks later, or a couple of weeks later.
I did.
And then you said you planned to go and see your son or something you never thought you would be able to do.
That's right, because he was working abroad. And I did go.
Did you go? Oh, I forgot. I didn't ask you that, whether you went or not.
Yes, I did go. It was great. Yeah. And then I took Paulie again. On and off for the last 3 years.
Did you find that was your mainly your mind and your life at the time?
Yes, I had a lot to do with it. Definitely. Yeah, I totally believe that the more positive you are, although you're still going to feel pain, and if you eat the wrong food, you're still going to be poorly. But just knowing that if you get into that mindset where you can do something about it instead of, feeling sorry for yourself, you've got to actually physically do something. And as I say, when I got your book, wow, that was amazing. Because that just came out the blue, unexpected. And at that time, I was really, really low. So the first thing I did was open it, start reading it, and then I got taken into hospital. I took the book with me to the hospital.
Okay.
And it was just amazing. A lot of the stuff in the book was what I already know myself.
Yep.
But you slip back and you forget, and you don't keep up with the positivity and you know you can do these things, but having that now Every time I feel a bit low or I just pick it up and start reading it, and then I feel better.
Oh, honey, that's
so that
great.
has greatly helped me.
I think it's also because we get hope taken away from us when we're sick. We trust the medical profession to be the only answer, because they're only mainly dealing with symptoms as opposed to really asking us, what's been going on in our life beforehand. And I think when you realise that you do have a choice, and this does give you your power, this creates energy, and then all of a sudden you can start to make choices and changes in your life. So no, that's great. Oh, thanks for sharing. I just wanted for everyone to know that for Anne, she's been had the major operation and still moving forward from where she is at the moment, but has made great changes, and she's so alive. You went driving yesterday, and she's been driving her car.
I certainly did.
Which is great. Oh, well, thanks for sharing that, Anne. I'll cut it off now. I'll cut it off from the recording and get back to you. So there you go, guys.
Right.
That was Anne. Where are you? Where are you, in Liverpool?
On the Wirral, yeah.
She's on the Wirral. She's in the Wirral. So that's her.
Posh.
She's posh, eh? All right, thanks, Anne. I'll just switch them off and I'll get back to you. Okay. Bye. Bye from Anne. Bye from me.